So we have an interesting potpourri of cases, presentations by very experienced speakers, and I will suggest that we can start the session on time. There's going to be a talk by Dr. Grover on orbital decompression. I myself will speak on AI and ophthalmology, and Dr. Uma Sridhar, challenging case scenarios and microbial keratitis. So for now, three of us are here, so I think we can start the session. So while Dr. Grover is setting up his slides, I'll start with my talk. Okay, so just to give you a little insight as to the potential that AI can have in ophthalmology, everybody is already aware that there is a vast variety of work going on internationally, and this is a very exciting area which is going to touch everybody's lives. Our own personal experience for looking at digital health solutions in eye care has been in joint collaboration with the Ministry of Health and Family Welfare, the e-health division, powered by Vadhani AI. Now, we know that global eye health is defined as a degree to which vision, ocular health, and function are maximized worldwide, thereby optimizing overall well being and quality of life. And to reach every single person in every corner, AI is a wonderful solution. At AIMS, our idea has been to have a problem statement, and All India Institute has wanted to facilitate the use of AI for the various national programs, starting with the ones where AI was ready, where we were AI compliant and ready to reach a solution. So it's not that it is limited to only these areas, but these were the areas where it was felt that the AI applications could make a huge difference. So cancer screening, chronic disorder management, National Program for Control of Blindness and Visual Impairment, that's where we have a role, infectious disorders and radiology, and maternal and child health. Now, looking at ophthalmology, the main areas would be anterior segment disorders, ocular oncology, posterior segment disorders, and refractive error detection. So these are the priority areas. However, we're not yet ready to start AI in each and every one of these spheres, plus giving a prioritization in terms of the impact. It was decided that we would start with diabetic retinopathy, led by Dr. Pradeep Venkatesh, Dr. Rohan Chawla, along with the rest of the team RPC. Why the collaboration was needed? Because Government of India is prioritizing AI and digital technology to revolutionize the healthcare industry in keeping with the concept of Viksit Bharat. And AIMS Delhi is working as a center of excellence for AI with the Ministry of Health and Family Welfare. And here we are not trying to be very occlusive or obstructive in our approach. We feel that we need to reach out and have a collaborative approach. So whichever institution would like to join hands with us, they're welcome to join, and we are happy to add them to the team. Now, the primary objectives in the study related to diabetic retinopathy was to get the engineering team to understand various aspects, because often we have excellent expertise in various domains, but nobody has maybe the opportunity or sometimes the time or maybe even the possibility to engage and learn from each other what are the issues. So just to give a simple snapshot, just the simple thing of the engineering team visiting the peripheral sites where patients are coming, and to actually see the level of patients, etc., and also the healthcare workers, what kind of caliber they have. All that helped to sort of understand the interface and give a kind of a perspective into the work that they were doing. And I would like to add, it is a very India-centric approach, but whatever is India-centric can still eventually be adapted to the rest of the world, not only the developing countries, even in the developed countries. There is a challenge to get this technology right across borders to the elderly and peripheral locations and so on. Now, we started in a very kind of a back foot. We started on the back foot because we already knew there was this huge thing going on with Google, and we also knew that they were very successful. But our only thing was that we need to have something locally, something which was indigenous and in our sort of ownership domain. So we also felt that how would we go about it? It would require millions of images, this, that, and the other. together. And also, what was eventually, if you don't plan properly, you're going to end up in the wrong spot. So we looked at what are the strengths and weaknesses, and we felt that there is a requirement to go for low-cost devices, have a device agnostic system, and also if you're going to compare grays versus black and white, maybe there's a different approach to how the AI engineers can develop it. So maybe you can develop it faster if you're teaching somebody to differentiate black and white, whereas you require more training to differentiate various segments of grays. So there was a lot of back and forth, and I must give credit to the Vadhani team that they had a lot of young and enthusiastic people who were willing to work and try to understand this interface. So we started like this. So to assess the accuracy of an AI solution, assess the agreement and so on, and I'm not going to waste time on the study design, data source and sample size because there is a shortage of time. The other interesting thing is we felt that we have only high-end fundus cameras. So we'll have to first purchase a low-end fundus camera and then we'll have to train it, because we wanted that it should be available at least at the district level. This is something you cannot give in the hands of ASHA workers for diabetic retinopathy, but yes, at least at the district level. So we felt that at least a fundus camera, which is low end, which can cost 2 to 3 lakhs or 4 lakhs, is affordable, but we didn't have them ourselves. However, the Vadhani team, I'm just mentioning Vadhani because that's the team we worked with, but I'm sure any other engineering team would have, come across with probably the same advice that you don't have to do that. You can train on high end, and then they said, no, don't worry, we'll manage it. So we worked like that with our existing resources, and we then wanted to develop a disease agnostic. So this is what made a difference. Our thinking, by the brainstorming with their thinking, we were able to correct some of our misconceptions. And then the initial thing that we worked out gave up a sensitivity of 90% and a specificity of 92%, which first we thought that no, there's something wrong, it's not possible. And the thing is that when I mentioned black and white, it was more to train it to detect vision threatening or referable DR. Diabetic retinopathy. So we went to get further and then try to compare it with further images, the community collected images. And there again, we had a sensitivity of 93% and a specificity of 95% and accuracy to 94% in detecting referable or sight-threatening retinopathy. And I can see some experts sitting at the back there, and I guess they will understand these charts. And so there was a kappa score of 0.88, and it was felt that in comparison to the gold standard also it was acceptable, and there was a near perfect agreement where we even then compared it with the validated commercially available software. Now we had to see what will be the diagnosis and can we employ it in the field. So once we had this confidence, we developed a workflow, referable versus non-referable, developed an app, started going initially to our own vision screening centers or our vision centers, and then again, we looked at evaluation of images from AIMS, images from the open data set, and the community ophthalmology evaluation using the low-cost fundus, phone camera screening and community setting. And across the board, it was a reliable model. So then we had prospective data results, and after that, we have now joined up with AIMS Rishikesh and AIMS BB Nagar. We sent it out to all the AIMS because we have a pan-AIMS research consortium. And even PGI Chandigarh, Dr. Vishali Vishali Gupta has also been enthusiastic. But in certain cases, there was a little hindrance in getting the low-cost camera to them. We had certain procedural delays. So at the moment, I would say AIMS Rishikesh has been the most proactive, and with the others, we're still in the process. And having reached that stage, we then were able to reach out to NHM and the government of Haryana, government of Rajasthan, Madhya Pradesh, and several NHMs all over the country. I think 7 or 8 states are now deploying it in their district hospitals, and this is further being so at the moment it is deployed, limited extents everywhere, still under the research mode. And finally, we have reached a stage where we can apply to CDSCO, and we have applied to CDSCO. CDSCO has given us the license to test license for testing. And after adequate data again, they will hopefully give us the license to roll it out as an accepted method. The challenge there is usually Cedisco gives this only to commercial entities, whereas we are a government entity. So at the moment, that was the hindrance. So they gave us a license to test. And they're going to work it out, how do they give the government a license to apply it. So that's in progress. And then other diseases as well, AMD, glaucoma, and retinoblastoma, refractive error, and anterior segment disease. These are all in progress. Screening at community vision centers, this is the concept that we'll have. So this is the AICOV and DR, there's a large burden, and then these are the methods of screening. And finally, we also worked out to close the loop where it was not enough just to detect. So when we found that out of all these patients, where these number of patients who had been detected, so in our periodic review, we were asked that what happened to those patients. So then we had to close the loop, confirm that had they come, and then we had to make a system where there was a feedback that the ones who were advised referral, did they actually go and what was the intervention. So this has also been incorporated into the system. So I'll stop here. Corneal opacity cataract, there are all various areas that we're working on. But I would, in a nutshell, I will say that there is a huge scope, and we were happy to get the Ministry of Education grant. But when I went to the award ceremony there, I learned a few things. There's a little difference in perspective of HRD Ministry and Ministry of Health and Family Welfare. And this I would like to share, because HRD Ministry wants that everything should be, you have to get some value out of it, which is also a good thing, because everything you give for free, then ultimately we have nothing to show as entrepreneurship. So while our work is useful, is good for the good of health, but at the same time, we need to, as a country, encourage the youngsters to work at things which are going to be internationally viable, that people will want to pay us for it, us meaning an Indian startup. So we have the capacity, we have the skills, we have the data, but we need to come up with ideas. So we not only look at low-end things, but also look at high-end things, which is going to be attractive for the rest of the world to purchase and get a multi-million rupee Indian startup in this field. There's a lot of scope, and this is, I feel, a good impetus from Ministry of HRD. Ministry of Health is absolutely the full support of this, and that's another responsibility. But simultaneously, I feel we need to also value the requirement of HRD Ministry, that as a country we need to be able to generate something which is world-worthy. Thank you so much. Yeah.
Thank you so much, ma'am. RPC is leading under your headship in the field of AI in ophthalmology. And Rajesh sir, any comments, any questions from the audience?
I think actually AI is the way to go. I mean, it has a lot of future, and I am really, it's very pleasing to see that RPC is taking a lot of lead in this direction. Thanks to your leadership, ma'am, and of course all the contributors who are contributing in different subspecialties and taking it forward. We are going to have a few more projects also. We have applied to ICMR for some more projects also related to AI, and obviously in a few years from now things will be very much different.
May I ask a question? Is that audible?
Yes, please, yes. Just introduce yourself so everybody knows.
Yeah. Hello everyone, good morning. My name is Dipinder Sekho. I'm an AI engineer and entrepreneur from IIT Delhi, and we have a startup focused on AI in ophthalmology. Ma'am, we already connected, and very happy to see your comments. I just wanted to say that we'll be very willing to invest as well as commercialize some of this research that is going on, and would love to collaborate further on any of the projects.
Thank you so much. What we'll do is we'll plan a half-day brainstorming. That's the only way. And I think as soon as this conference is over, we can maybe meet tomorrow and work out a method. Okay, thank you so much. So we're very happy to have Dr. Grover, and Dr. Grover is going to speak on an extremely important topic, orbital decompression for thyroid eye disease.
Ophthalmological Society for this opportunity to present before this audience of AIOC. So since this is a non-oculoplastic audience, I'll orient my talk to be explanatory to a general ophthalmologist. So the decompression for thyroid eye disease is required as the orbits become extremely bulky because of the immune response to the antigens which are circulating in the thyroid eye disease, and it's a response, immune response, just as the thyroid gland has a response which results in changes in the muscle, in the adipose tissue, and leads to extensive fluid accumulation, inflammation, and fibrosis. So the decompression is required when the deleterious effects of that bulge lead to corneal exposure or corneal keratitis with threatened visual loss, or an effect on the optic nerve due to the compression caused by extensive changes in the muscle close to the apex where nerve has very little space left. But increasingly, we are using it for indications other than the eye saving or the vision saving ones, like congestive changes taking place because of the compression that is taking place, congestion in the vessels, spontaneous globe luxations, and more for aesthetic reasons, where the person's life has been totally altered, shattered in fact, because of the changes in the aesthetics of the person. And it is vital for his or her confidence to be restored to face the world. Now, the kind of changes we have is the increased orbital fat or type 1 or enlarged extraocular muscles as in type 2, and the need for decompression may vary. So when a sight-threatening thyroid eye disease occurs, the first thing is to start with medical therapy, which may include a combination of corticosteroids and radiation, or steroids as intravenous therapy, and some initial reports with teprotumumab, but not yet supported by long-term results. So this is therapy has been shown to work well in a certain percentage of cases, but there would always be cases where they would require a decompression. Similarly, in stable phase, orbital decompression is needed first before any other surgical procedures can be done for correction of their aesthetics. So bony decompression is carried out by thinning the walls, that is one, and two, by decreasing the volume of fat or fat decompression. And for compressive neuropathy, the target is to involve muscles close to the orbital apex, and those are the bones then that are tackled. For stable thyroid eye disease, the greater emphasis is on the bones posteriorly so that the eyeball can go back. So for compressive optic neuropathy, it will be the deeper part of the sphenoid or the ethmoids or the part of the inferomedial strut, the posterior part, which are close to the apex. So when we want to reduce proptosis, we first start with decreasing the orbital fat as the first step. If we need further, we go on to the lateral wall, then to the medial wall, and then to the floor. But we do this because the risk for double vision increases as we proceed to these later walls. So the approaches are now aesthetic approaches. We approach the orbit either through an incision hidden in the eyelid crease or in the conjunctiva, which implies that we do not leave behind an aesthetic scar. The problem that is most commonly occurring post-operatively is worsening of diplopia, which is what needs to be guarded against. So the orbital decompression is customized as what is appropriate for a muscle predominant disease or a fat predominant disease, and accordingly the bone or fat may be prioritized for removal. I'll just show you a brief glimpse in a minute of the walls for decompression. This is a patient with neuropathy. So we are using the lid crease incision here, and after the periosteum is incised and periorbita opened up, we start decompressing the walls by trimming the surface to get a better approach, and then thinning out the walls with the help of the burrs. On the medial side, it is done in a different way but most often we use these bursts. So we need pre-op CT imaging to tell us how much we can thin a wall. And this can give us extremely gratifying results in reduction of compressive optic neuropathy, with vision improving over the next 6 months to 1 year from as low as 360 to 6.6 or 6.9 in many cases. So a congestive orbitopathy can be all totally resolved. Pain, glaucoma that is not responding, or pressure eyes that is not responding, that responds well to decompression. Transconjunctival decompression implies that you are able to give extremely aesthetic results. Thank you very much. Hope I could convey something.
Thank you, sir. I mean, you conveyed a lot, actually. And it was wonderful to see all those cases and the situations that you presented. Thanks a lot. Any question for Sir, Dr. Grover? If you don't have, then we will move on to the next speaker, Dr. Uma Sridhar. And she'll be talking about challenging case scenarios in microbial keratitis.
Thank you, Delhi Ophthalmic Society and Praful, for this opportunity. These are 3 cases which I saw in the last 6 months, and they were pretty interesting by themselves, and they had reasonably good outcomes, so I think that's why I'm presenting them. A 25-year-old male patient, he was treated for adenoviral conjunctivitis with the usual combination of steroids, antibiotics, and he presented with this picture. You can see these multiple infiltrates here, which look very interesting. And he had a lot of keratic precipitates also, and small, these are multiple infiltrates here. So what we did was we scraped and we started him on fortified tobramycin and linezolid and oral clarithromycin after the antibiotic, the microbiological results came in. You can see here atypical mycobacteria, which was 20% acid fast, positive here, growing on blood and chocolate agar. And then we saw that the sensitivity was there to linezolid, to clarithromycin and tobramycin. And so when we started him on that, first we started him on fortified amica. We stopped his Predfort, which was going on, and started him on oral clarithromycin. This was the initial picture after we had scraped him, and you can see that how his journey went. It was a long journey. In between, he actually improved here. You can see there was some improvement, and he had severe pain in between, and he would dictate his own treatment. He would take the oral medicine, sometimes not take it. Then he would tell me, we actually started topical clarithromycin. He used it for a certain while, he actually improved, and then he said it didn't work for him. He stopped it, he used oral, and he actually was governing his own treatment. And you can see how he was progressing over a period of time. And then when he stopped the topical clarithromycin and the oral, it actually increased. So there was a waxing and waning picture. And then when we again restarted, he improved. And over a period of time, it took a long period. You can see October, November, and then he stopped the clarithromycin. Finally, he started improving, scarring with vascularization. And finally, his visual improvement improved to 6/12. So here, I can say that the patient actually dictated his treatment. He wasn't stopping his topical drops. He was on fortified amica. He was on linezolid. And in between, he took oral clarithromycin. I was not sure of how long he can take the oral clarithromycin. So he took it for 2 weeks. Then he stopped it. He restarted. So ultimate result was now he is waiting. Maybe we'll start losartan after a while, topical. We are giving it to a lot of patients to reduce the scarring. But he is pain-free and comfortable. But atypical, as you know, has a long waxing and waning course, and it can come back. So we are keeping an eye on him. At present, he is fine. The next case we had was a community patient who came with this kind of an infiltrate, keratinization. His OSSN had already been removed elsewhere. So when we scraped this, we found a lot of fungal hyphae. And then after discussion, I would give credit to my oculoplastic colleague, Dr. Jyoti Ori. We couldn't give topical interferon here on the scare of kind of increasing his fungal keratitis. We are giving him topical natamycin. So we gave him perilesional interferon injection, that is 3 million international units every 2 weeks. And he actually started resolving along with topical natamycin. So every 2 weeks he was given interferon. And you can see that finally the OSSN resolved, the cornea is scarred, and he's got a cataract, he's waiting for his surgery. He's about 624 vision now. And recently also I saw him this month, and he looks so much better from his previous picture. The third case was a young lady who came from London, and she was actually wearing, she was a contact lens wearer, probably got wet in the rain. Then after that, after a week, she traveled, and she had a lot of congestion, redness, and she was referred to me by a former resident saying that she had some small infiltrates here. And then going by our the usual antibiotics with sensitivity patterns, after scraping, I started her on fortified, she was already on Viga, but I then started her on fortified tobramycin and ciprofloxacin, and she actually worsened, and she had severe pain. Then we changed when we saw GPC and bacilli and no response to fortified toba and Ciplox, changed it to Ciplox and amikacin. So then again, there was no growth on culture. We re-scraped her. She actually had severe pain. Then knowing that she had responded to Viga initially, we shifted the Ciplox to Viga Master. Then you can see the progress. Initially, she came like this. She worsened. Then here, there was some S-shaped infiltrate here. And then knowing that sometimes sensitivity patterns, it can be sensitive to linezolid, we started her on that. But the pain did not reduce. She came every second day with severe pain, and the infiltrate kept progressing. So she went to another center, that is Shroff Eye Center. They scraped her again found nothing. Then with linezolid, she actually improved a little bit with linezolid and Viga. And we thought she was better, but severe pain was there. So we re-scraped, and finally in the fourth scraping, she came out as acanthamoeba. So we got PHMB and chlorhexidine again from Shroff. Linezolid is supposed to also, may not be anecdotally also, but also the acanthamoebas seem to have responded to it. So PHMB, chlorhexidine, Viga and linezolid. And then we stopped the Viga, continued with PHMB and chlorhexidine. And then we found she kept improving, and finally her vision is around 612. She's a myope, so it's about 3.75. Maybe we'll start losartan again, but she's very comfortable, and we are keeping an eye on this. So the moral of the story is microbiological support is very helpful. And the other thing is the atypical organisms need long-term follow-up, patience from the patient side and from us. Thank you.
Thank you very much, Dr. Uma. It was, these cases were really interesting, and I would say, I mean, a lot of food for thought, thought-provoking kind of that what more can be done, and very nicely managed. Just one thing I wanted to ask, what was the percentage of PHMB and chlorhexidine that you used? I mean, you used both the drugs?
Yeah, we got
together.
it from Shroff. So 0.02 was chlorhexidine,
Okay.
and PHMB I think was 0.1,
0.02,
but we just
0.02.
gave it there. We gave it to Shroff, and they mixed it up for us. So we didn't mix it ourselves.
Okay,
Earlier
okay.
I used to use the mouthwash and use 1 cc of mouthwash with 10 cc and then get that
Okay.
0.02%. But that also we didn't have infection. I would say fingers crossed. But now I think Shroff Pharmacy is preparing it,
yeah.
so we are able to get. I think Ames also
Yeah.
prepares it.
Yeah. So I was just thinking that maybe just instead of combining, I mean, are you fond of combining PHMB and chlorhexidine, or maybe
usually-
going with a higher concentration of PHMB, maybe
I'm not sure about the
0.08%?
toxicity of that. Maybe you
People
are
have
more
used
experienced
higher
there.
concentration of
I think
PHMB
so.
alone.
Recently the ODAC trial that has come in has shown that PHMB 0.08% has
Yeah.
equal efficacy to the
Okay.
combination therapy. But I think that's the only
Yeah.
study that has come up with it.
Yeah,
So
yeah.
That's why I usually we don't get access to PHMB. So I have seen in 20 years only
Yeah.
6 cases of acanthamoeba. So this one, even though she was a contact lens wearer, she had worn it 1 week ago. And the pattern, after 4 scrapings, it came out, So, and the only clue was severe pain.
Yeah, all these cases are really very tricky, and Dr. Tejas has to say something.
I just wanted to, if we can go back to the first
Paras,
case, like, are we seeing more number of microsporidial keratitis of late? Because this is becoming very common. Even sometimes a patient presenting with PUK, and you just scrape and it turns out to be the one which is not responding. The battery of investigations have been absolutely normal, and then they turn out to have microsporidial stromal keratitis. And that is what, even in her case,
Mine
Yeah.
was atypical mycobacteria in the first one, and the second one was fungus with OSSN, and the third one was acanthamoeba.
yeah.
Microsporidia stromal, of late we
Of
are
late
suspecting and
we are
seeing.
seeing more
Yeah.
cases like,
Actually, Dr. Paras, you are, what you are telling is, sometimes we do face, and microsporidia keratitis, till the time it is epithelial, it responds very well to either you can use a moxifloxacin, or if it's not working, you can
we are
even do
seeing more
debridement.
often stromal rather than
But if it goes into stromal, then it becomes devastating actually. That is the biggest problem with microsporidia. Till the time it is epithelial, it is still controllable. Once it goes into stroma, many times you have to do a therapeutic graft. That's the problem. Anyways, we move on, and thank you very much, Dr. Uma. And next we have Dr. J.S. Balla, and he'll be talking about intumescent cataract, Indian design to combat Argentinian flag sign.
The slides are not coming over here. Audio visual? Excuse me. Yeah. Good morning. At the outset, I'm thankful to DOS, Dr. Rajesh and Dr. Prafulla for giving me this opportunity. The topic I'm going to cover is how to prevent Argentinian flag sign and intumescent white cataracts. While there is no standard definition for intumescent cataract in the literature, Brazitikos defined it as a cataract with flocculent cortex, while Centurion was more objective and it defined any cataract thicker than 5.5 millimeter, AC angle less than 45 degree and ACD less than 2.2 millimeter are the features of intumescent white cataract. There are three basic pathologies which lead to weakening of the anterior capsule and equatorial extension leading to Argentinian flag sign, and these are high intralenticular pressure, loss of lens structural integrity and thinning of the lens capsule. So we thought, is there a way to objectively find out which of these intumescent white cataracts are going to develop Argentinian flag sign and which are not? Because all intumescent cataract do not land up with this dreaded complication. So we thought there is a potential role of preoperative anterior segment OCT to find whether there is presence or absence of fluid pockets, whether it is subcapsular or intralenticular, what is location of these fluid pockets, whether it is peripheral or central, and what is depth and size of these fluid pockets, because we found this helps us in better planning of the surgical technique. So if you see these anterior segment OCT pictures, the one on the top left is predominantly central subcapsular fluid pocket, on the right is predominantly peripheral subcapsular fluid pocket, and the third one is both central and peripheral, and fourth is there is no subcapsular fluid pocket, only intralenticular fluid pockets without subcapsular fluid. We all know there are some challenges during management of intumescent cataract. There is absence of lead reflex, high intralenticular pressure, leaking of liquefied cortex, which make visibility difficult, fragile anterior capsule, which runs away to the equator, leading to Argentinian flag sign. So various techniques have been described in the literature by Figurado, Panchorexis, sewing needle, capsule milking by Chi Soon Fake of Singapore. So we made an algorithm. If there is a subcapsular fluid and it is predominantly central, it makes no sense to touch this bulging, tense anterior capsule in the center, because this is where the intralenticular pressure is highest. And so we describe a technique which is known as peripheral capsulorhexis. So instead of going through the center, we go through the periphery. And if it is predominantly peripheral subcapsular fluid pocket, then we do central capsulorhexis, but not the usual one, but two-stage. First, we make a small capsulorhexis and then extend it to size of 5.5. And if it is diffuse, then since there is a central subcapsular fluid pocket also as an element, we again do peripheral capsulorhexis. And if there is no subcapsular fluid pocket, then we can go ahead and do routine central capsular access, because these patients without subcapsular fluid pocket are not going to land up with Argentinian flag sign. So this is how we do the initially 3.3 millimeter, the 3 millimeter capsular access, and then give a nick in the circumference and then just rotate it with micro-uterata forceps. I won't go into the detail. But peripheral capsular access is done where you have the element of central subcapsular fluid pocket. We did some out-of-the-box thinking, because the moment you touch center of a bulging tense... Sound, can you increase the sound? Is bound to have a linear radial rupture. So we did a small experiment on balloon, where instead of puncturing the bulging center, we punctured the periphery. And voila! So here no we did an experiment that instead of going through the center, we went through the periphery, and we found that there was no rupture of the balloon. This gave us an idea that it is possible. So we bend a needle at the junction of the peripheral 1/3 and central 2/3 and go through the periphery of the anterior capsule, just in central to the insertion of the zonules, that is a peripheral 2/3, central 2/3 and peripheral 1/3 with bevel down, go right up to the center with bevel down, aspirate the intralenticular fluid so that intralenticular pressure decreases. Then through this incision, we give with the nick in the micro scissor right up to the center. So, and we made 2 flaps are created. So these 2 flaps, after injecting visco-cohesive, viscoelastic, now we go through one of the side port, catch hold of one of the flap and rotate it clockwise in a clockwise direction. And through the other side port, we go and rotate the flap in counterclockwise direction, and then we meet these 2 and we have a round capsular access. So I'll again explain in detail in slow motion. Main port, make a puncture at the junction of the peripheral 1/3 and central 2/3 of the capsular bag. With bevel down, aspirate intralenticular fluid, you find that intralenticular pressure is decreasing. And why this nick does not extend peripherally is because this is a circumferential cut and not a radial cut. It is the radial cut which has the tendency. And now we give a nick into the right up to the center, and 2 flaps are created. And these 2 flaps can be rotated. Viscoelastic, and what you have to do now is raise this peripheral flap. First pick up the first peripheral flap, rotate it circumferentially. It's a very simple technique. We had done a thesis on that, and this was published in July edition of IGO with video also. You can go through the details. We have won 2 World Cups in our cricket because of peripheral catches. So it becomes very simple to bail us out of a difficult situation of Argentinian flag sign just by this peripheral access. So the way to go in intumescent cataract is to start doing peripheral capsular access. If you have access to anterior segment OCT, it is good. But if you don't, then start doing peripheral capsular access in all your patients. So knowing what you are going to encounter on the table helps you to be better prepared pre-operatively to handle such cases, rather than discovering it on the table during surgery and then planning on how to go about it, because forewarned is forearmed, and employing just one technique for all types of intumescent cataract will not yield desirable outcomes. Customizing and tailoring the technique of management of such cases according to the situation on hand is the right strategy, because one key may not open all the locks. Thank you everyone for your kind and patient hearing.
Thank you so much, sir, for that wonderful talk and those beautiful videos and the algorithm that you showed. It's really very nice to have this presentation. Thank you so much, sir. Do we have any comments from the panelists here?
So, very nice presentation and a very nice idea. So we have been doing a different technique for intumescent cataracts. We've been massaging the intumescent lens to displace the fluid from the center to the periphery. And then subsequently what we have found when we make the opening, actually the fluid gets displaced and we are able to make a central capsular access. I've sent this video to ASCRS this year and a paper as well. We've compared 2 different techniques. So, you know, it's something that we can come up with different ideas on how to conquer intumescent cataract, because it's something that that we'll always land up in trouble when we are making a rexus.
Exactly. There are many ways to skin the cat. Yes, this technique is very well described by you and also by Chi Soon Fake of Singapore, where she does the milking technique. From center, the fluid is displaced to the mid-periphery. Because of the natural biconvex shape of the crystalline lens, the intralenticular pressure is highest in the center. And if you see that the volume is about 4/3 pi r cube, and that translates into high intralenticular pressure. By massaging, sometimes what happens is you may inadvertently cause rupture, which is possible in some cases, but here you are touching the safe zone of the capsule. You are not going to the center at all, and by going to the safe zone, the chances of inadvertent equatorial extension are quite minimal. Yeah, thank you.
Thank you.
I think the debate will never stop as to which is the right and perfect technique for intumescent cataracts. So with that, we'll move on to the next presenter. We have Dr. Alkesh Chaudhary sir here, who's an eminent retina specialist. He's practicing in Delhi, and he'll be talking about successful management of endophthalmitis with scleral melting.
Good morning, everyone. I feel it is my privilege to be part of this DOS session because I always feel belonging to the DOS. So I feel it is my privilege and my commitment also to be part of this and make it more successful. And I'll be presenting a typical case of management of endophthalmitis with scleral melting. Scleral buckling is a procedure to manage rheumatism RD. Now it is less used, but it's still important. And you can see the buckle being used. And before and how we place the buckle around the sclera to give the indentation and close the break. Buccal infection now. Buccal exposure, sometimes this buccal get exposed out of the conjunctiva and causes infection. So there was once 57-year-old operated for RD, right eye with scleral buckle and band 4 years back. Referred for management of endophthalmitis with best corrected visibility of PL positive, PR accurate. History of recurrent extraocular infection for last 1 year and treated with topical antibiotic and sometime with oral antibiotic, but no culture reports available. It was being treated somewhere else. So gross examination when it came to me, corneal congestion with mucopollulant discharge, ciliary tenderness, moderate level, hypotony, extraocular movement, full and with mild pain, corneal haze with cells and flare in anterior chamber, scleral melting with buccal exposure in inferior temporal quadrant, fundus novus hazy media. If you see the picture, this is complete scleral melting with a choroidal exposure. You can see here, and if you see carefully, there is a buccal exposure here, extending up to here, but it was never examined for that and just being treated as a conjunctivitis. Slit time examination shows flare, gross flare and cells. Investigation B scan, ultrasound showed retina on with early choroidal 360 degree. Indirect ophthalmoscopy, no view, conjunctival swab for culture sensitivity negative, probably due to earlier use of frequent antibiotics. Management, how we manage this case, 1 in 10 dilution betadine wash, repeated, buccal removal was done, scleral grafting was done, intravitreal subconjunctival vancomycin given, and oral antibiotic. After 1 month, conjunctival graft was done on scleral, successful. You see this is scleral melting and how bad is the sclera being melted all over, and it was covered with the scleral graft. Showing a small video carefully was done so that we don't cause further globe perforation. You see carefully this buccal being removed, because all of this buccal is removed, then band is being removed, and you see the scleral patches being sutured all around after betadine wash and doing all clearing. And intravitreal vancomycin was injected. Then conjunctival graft after 1 month was done. See, the area was measured and we applied some suture to pull it because it was deep in the inferior temporal quadrant. Conjunctival injection being done so that we can make small conjunctival opening where we can put the scleral graft, conjunctival graft, sorry. So conjunctival was taken from the superior quadrant, and finally you see the conjunctiva was sutured in that area where the scleral graft was done. Outcome was best corrected visual acuity was 20/80. He could recover well, +3. IOP normal 12 millimeter. Anterior and posterior chamber quite. Sclera and conjunctiva graft were well taken up and retina on. If you see carefully, this well taken up scleral graft area, conjunctival graft well taken up, quite eye, red glow clearly visible, no cells, no flare. Follow up with slit lamp, clear pictures if you see no cells, no flare. Follow fundus picture, retina on, and patient doing well. And after 3 months, there was a recurrent RD, 25 gauge VR surgery planned, and it was done. You see, post VR, these are all oil reflexes, retina on, and status post VR surgery. Again, patient did well and recovered back to vision. 6/18. Post scleral implant buccal surgery. Always inspect for any buccal exposure. Don't ignore. If there is infection, post buccal infection, do examine them. Don't miss any buccal exposure, and just don't treat like antibiotic, so that we can manage successfully. Thank you. Dr. Amit is here. I think he can highlight something. Dr. Sanjeev.
So I think it was a very interesting talk, and some of the complication, the cases can be retinal incarceration also, because when the
Yes.
buccal is exposed and the
Yeah.
scleral necrosis.
Luckily, we didn't have, because you see the sclera, the way it was melted,
Yeah.
it can lead to a devastating complication, endophthalmitis, and we lose whole of the eye even.
Yeah. So luckily it was not the case
Yeah.
here. It was
I think
nice.
it was a
present.
well managed case, and I think a lot of time when you see a scleral melt, you just say, okay, nothing more can be done. But at least by doing these procedures, you can salvage
Yeah,
the
I
eye.
just made an attempt, took a good chance, and we could save the eye.
Yeah.
Thank you. Thank you so much.
Next, Dr. Ashu sir is not here. Dr. Ashu Agarwal is not here, and then we'll have Dr. Ikeda for her talk on a closer look at dry eye in Sjogren syndrome, a case-based presentation.
नहीं चलेगा.
A very good morning. I will be going through some of the cases of Sjogren syndrome and discussing what we really do and how we manage these cases. Can we have the slides, please?
संजय ये वाला आ गया, ये वाला आ गया.
ये हटा दो, ये वाला व्यू हटा दो, नॉर्मल व्यू कर दो.
भाई मेरा वाला है. तो भाई ये मेरा वाला है.
उधर लगा दो, अगर उधर कनेक्टेड है ना, ये हो जाएगा.
एक मिनट आएगा देख देख डुप्लीकेट का किया
All right, sorry about that, a slight AV glitch. So I'll straight away go to my first case. This is a 57-year-old female patient, and she came to us with complaints of intermittent irritation and redness, which was associated with blurred vision in both the eyes. She was more symptomatic in her left eye than the right eye, and the symptoms were persisting since 1 year. She did give us history of occasional dryness of mouth and the frequent need to drink water, which was associated with dental cavities for which she had undergone multiple interventions. There was no history of stiffness of small joints, skin rashes, or repeated mucosal ulceration. So all this history is important to us when we're looking at a patient like this where we are suspecting Sjogren's syndrome, because this can give us clues to the underlying diagnosis of the disease. She also had history of hypothyroidism for which she was on levothyroxine and rosuvastatin for cholesterol. There was no history of medication use or for anxiety or allergies, and no history of any surgical procedure. Again, sometimes we can get drug-induced dry eye, which we may confuse with other causes of aqueous deficiency dry eye. Therefore, typically these anti-anxiety and anti-allergic medications need to be asked for. So when we examined her, this is what her ocular surface looks like. We can see that there is some amount of bulbar congestion, and there is tear film breakup. There are some SPKs. We can see that the ocular surface is taking up the stain. The tear meniscus height is reduced. And in the left eye, she was much more symptomatic than the right. We actually had to decrease the illumination to capture the images in the left eye. Now, in this ocular surface staining, what I want you to look at is that she does have a complete blink, but as soon as she opens her eyes, there is an area break in the interpalpebral zone. And this kind of a pattern of the tear film breakup time has been described by the Asian Society, and this is indicative of an aqueous deficiency dry eye. Also, it helps to look at the palpebral lobe of the lacrimal gland. When we do a direct examination, the lobe in patients with Sjogren's syndrome does not look as pink, it is paler. And when we look at it under the staining of the fluorescent, we might not be able to appreciate the tear secretion as we can do in normal cases. So her Schirmer's was reduced. Right eye was 8 mm and left eye was 6 mm at 5 minutes without anesthesia. It is important to be consistent in the way that we do the Schirmer's, and repeatedly we have to measure it in the similar way. She also had significant cataract and had an ERM in the left eye. So with this, her clinical diagnosis was aqueous deficiency dry eye, a probable primary or secondary Sjogren's syndrome. Now, before I begin talk about how we manage this, we'll look at the ocular management, what we started her on. We gave her lubricants or tear substitutes 6 times per day, HPMC gel as well 2 times per day. We started her on 0.09% cyclosporin as well as fluorometholone in tapering doses. So the idea is that by the time cyclosporin starts acting, the fluorometholone is tapered off, and this will give her symptomatic relief. Now, it is important that we refer these patients to the rheumatologist to look for diagnosis of Sjogren's syndrome. And this is the typical battery of investigations that are ordered for these patients. A complete blood picture, ESR and CRP. CRP is indicative of the inflammation going on in the body. A rheumatoid factor, anti-CCP antibodies. Now, anti-CCP antibodies are actually much more specific for rheumatoid arthritis. There is some crosstalk in rheumatoid factor where we have primary Sjogren's syndrome, but rheumatoid factor can still come positive even if the patient does not have underlying rheumatoid arthritis. An ANA profile to look for SLE, which can be the underlying reason for Sjogren's syndrome, anti-ROLA antibodies for primary Sjogren's, a thyroid function test, otherwise also, and in this case because the patient had history of hypothyroidism, and a serum ACE to rule out sarcoidosis. Now, the rheumatologist saw her and did not find any underlying autoimmune disorder, although she was anti-Ro antibody positive, and that's how primary diagnosis of primary Sjogren's syndrome was made. So she did not have any extra glandular manifestation like Raynaud's or pulmonary involvement in this case. So no immunomodulatory therapy was prescribed, and she was only given oral pilocarpine 5 mg BD. Now, this is the criteria that is typically used by the rheumatologist to diagnose Sjogren's syndrome. Now, it is important to understand that apart from the symptoms and the exclusion criteria, the most score that has been given is to anti-SSA or anti-Rho positive antibodies or to a salivary gland biopsy. Salivary gland biopsy is not typically performed by most of the rheumatologists these days. We actually do an ultrasound to look at the salivary gland. So if the patient does not come out to be antibody positive, then by this typical criteria, actually we cannot say that this patient has primary Sjogren's syndrome. Now at 1 month follow-up, her surface looks significantly better. She symptomatically improved. And we kept her on follow-up for a long time. She was continued on tear substitutes and cyclosporin and oral pilocarpine. The ocular surface was stable, and subsequently when her vision dropped, she was planned for cataract surgery. Now it is important that we do not rush in cases like this for cataract surgery. We need to make sure that the surface is stable. We need to counsel them that there will be increase in symptoms of dry eye after cataract surgery as well. Sometimes we might need to give them oral steroids before we take up these patients for cataract surgery. And some of the precautions I'd like to highlight is that we need to limit the incisional damage, avoid any astigmatic keratotomies or LRIs, avoid excessive anesthetic drop application, as well as just put a single drop of povidone iodine. Do not give any NSAIDs pre-op or post-op. To avoid limited repeated drying during the procedure, we can coat the ocular surface with a dispersive OVD. This works better than repeated irrigation with VSS. We need to keep the illumination a little low so that the patient is comfortable, especially because most of these cases these days we are doing in topical anesthesia. So it should not be excessive, and of course reduce the surgical time as well. A word of caution with flax suction ring, because it actually sits on the conjunctiva, can do more harm than good. We need to keep our ocular surface handling to the minimal and avoid holding with forceps. So here is just a short video to highlight some of the things that I just discussed. So here I'm using a chopper rather than using LIMS forceps, and coating the ocular surface with a dispersive OVD. So this patient has now undergone cataract surgery for both the eyes. Again, I'm not holding any forceps, just using my chopper for all my incisions. The phaco part is pretty routine in these patients, and we implanted a monofocal IOL in the back. If the patient has severe dry eye, we need to avoid trifocal IOLs for these cases. Now this is 6 months after cataract surgery. The ocular surface is stable. She is on follow-up with us. Her visual acuity is 20/20 in the right eye and 20/30 in the left due to ERM. She is on tear substitutes and cyclosporin with the stable Schirmers. Now a second case is a little different. Case 2 is that of a 52-year-old female patient who is symptomatic in her left eye since the past 15 days. She has history of right eye keratoplasty performed elsewhere 2 years ago. There are no records available, but she said she had a melt in that eye. She also has history of associated rheumatoid arthritis, but she is non-compliant with the treatment and she has stopped all treatment. She actually did not want to get her right eye examined at all, and she wanted us to only look at her left eye. So this is her left eye. Her visual acuity is 20/60. So I'll just talk about her left eye over here. We can see that she has a PUK here, apart from the dry ocular surface that we can examine in this patient. So here the right eye had a failed graft, the left eye has aqueous deficiency dry eye with PUK with an underlying rheumatoid arthritis. So this is secondary Sjogren's syndrome, and very important that we counsel her and tell her, because these patients don't understand that their eye involvement is because of their rheumatoid arthritis, and send her back to the rheumatologist to restart immunomodulation. Her RA factor was very high at 108. She was started on methotrexate as well as oral hydroxychloroquine. And topically we gave her tear substitutes along with HPMC gel cyclosporin. She was also given steroids in view of PUK, tapering in prednisolone acetate, which was weekly tapered under the cover of moxifloxacin eye drops. So 5 days later she has improved. We can see that the PUK is nearly healed, and we have counseled her repeatedly that you need to continue systemic immunomodulation. We don't want a melt like this in the left eye as you've had in the right eye. And topically she is maintained on tear substitutes and cyclosporins. So to conclude, Sjogren's syndrome can be primary or secondary. Primary Sjogren's syndrome and secondary Sjogren's syndrome is best diagnosed in collaboration with the rheumatologist, because they do require a battery of investigations to be able to differentiate between the two. So we need to have a good coordination. Primary Sjogren's syndrome typically requires topical therapy. If there is only ocular involvement, they may not need systemic immunomodulation until and unless there are extragranular manifestations. Whereas secondary Sjogren's syndrome, systemic immunomodulation is the mainstay of therapy along with topical therapy. Thank you.
Thank you, Dr. Aikida, for that wonderful presentation. We'll take the questions in the end. Next, we have Dr. Prafulla Maharana, who is additional professor at RP Center and secretary of DOS. He's an eminent researcher and academician, and he'll be talking about non-healing keratitis, my approach. Can we have the presentation, please, audio-visual team? And can we have Dr. Ashu's presentation also ready on the next dice, please?
Good morning, everyone. Thank you so much for being here in this DOS session. And we are happy that this time the participation is much better than APAO DOS session. So thank you to all the delegates. So I'll be speaking on non-healing keratitis, my approach. So I'll just wind up in 5 minutes because I think we are running a little late. So I'll be highlighting few of the study that we have done over last 5 years for cases of non-healing keratitis, with a focus on one novel study that we did. So, okay. So, non-healing, we know in bacterial keratitis, if it's not responding beyond 48 hours, in fungus beyond 1 week. इसमें अब इसमें क्या करूँ? फ्रेंड्स हो, यही तो है. ये आना चाहिए ना.
We can see it now. We can see it now.
Not coming there. So, okay. So what are the factors that lead to non-healing? There could be many factors. Most importantly, it may be the patient, or maybe the physician, or maybe the drug that you are giving, or maybe the organism resistant to that. क्या कर रहा है ये? Okay. So the first study that we did, we tried to measure the corneal concentration of drug that we are commonly using in fungal keratitis, and we correlated the MIC level of those organisms. So the idea was that till so far, क्या nonsense चल रहा है तुम्हारा, अभी बंद कर दे सेशन. क्या? So the idea was to know with the drug that we are prescribing to the patient, if it is crossing the minimum inhibitory concentration that is required to kill those organisms. I hope you people know what is MIC 90. It's the minimum concentration that inhibits the growth of 90% of the organism. So what we did, we went ahead with cases of fungal keratitis, those were not responding to routine drugs like natamycin and voriconazole. And when those patients were undergoing therapeutic penetrating keratoplasty, we took the corneal button. One half was sent to pharmacology department to measure the intracorneal concentration of the drug. The second half was sent for microbiology and MIC. Now, I'm not going to the detail of this procedure. We use LCMS to know the intracorneal concentration, and we use the E-test, although it's not standardized, but still that was the thing available to us in our lab. So we did the E-test to check for the MIC. Now, what are the major conclusions? This is very important, and it was little surprising to us also. So over 85% of the cases, the voriconazole concentration that was achieved in cornea was less than the MIC 90. But for natamycin, in 38% cases only it failed to cross the MIC. Now the important takeaway here is that classically we have been taught voriconazole has a good penetration. But if you go through the MUT trial study, they found that voriconazole is less effective than natamycin, and probably this study also highlights the same thing. Although the pharmacological principles suggest voriconazole has a better penetration, but practically when you are using in patients' eye, is the natamycin which is crossing beyond the MIC 90, not the voriconazole. Second thing that was quite surprising is in more than 50% of the cases where natamycin was crossing the MIC 90, the response was not there. The patient had to undergo a therapeutic graft, which again re-emphasizes the age-old concept. Drugs only helps in initial clearing. After that, the host immune system, it has to take over, and then it has to clear the fungus. So in more than 50% of the cases, the MIC, even it was crossing, they didn't respond. In these 50% of cases, most of them had either diabetes mellitus or some history of prolonged use of drugs for dry eye. So that is an important factor that we came across with this study. And lastly, infiltrate area, depth, epithelial defect, they didn't impact the MIC or the concentration of drug that was reaching in the cornea. So this suggests when you do corneal debridement, there is a age-old concept that it may help in drug penetration, but it's not. It was not there in our study. And second, this is again emphasizing the mud trial result. In mud trial, what they found, if you do debridement, the visual outcome may be poorer compared to those group where debridement was not done. So we published this in IGO, and fortunately we got the best paper in cornea in original category for this study. And this was largely the study that I wanted to discuss. Then there are few other trials that we did at RP Center for non-healing keratitis. One is what is the correlation between clinical and microbiological diagnosis, because in most part of India, you don't have a microbiology backup. So if somebody starts antifungal therapy just based on clinical diagnosis, how far it is correlating with the histopathological diagnosis. So what we took all the patients where the clear-cut provisional diagnosis was made by the clinician, either fungal or bacteria, and then we analyzed them. What we found that clinician can accurately predict only in 54% of the cases whether it is a fungal or the bacterial. Although in fungal it was little better, but bacteria it was quite poor. So the point to be taken here is, if you are not sure about the microbiology, if you don't have the access, it's better to refer to the patient rather than starting a cocktail of therapy, and that will lead to further worsening of the condition. Third study that we did, we evaluated corneal biopsy. Normally we do biopsy when ulcer is not healing and the smear result twice you have done, it's not showing any result. But what I feel, if a patient of fungal keratitis comes to you and it's not responding to treatment, you can directly go for a biopsy rather than waiting for a drug holiday period. And this is what even we found in our study. I'm not going to show all this thing. So this is the study we did, and what we found in fungal, you can see there is a statistically better result with corneal biopsy compared to corneal scraping. So if you are dealing with a case of fungal keratitis, it's not responding, go for biopsy directly, don't wait for corneal scraping. So this is the last one, oral antibiotic, do they have a role? Study after study they show that it doesn't have a role, but when we did the TST protocol, we found it is useful. So what we did, all patients who are on oral antibiotics, we took the tear film sample and measured the concentration, and we correlated that with the MIC level. So to our surprise, in almost all the patients, the tear film concentration that was achieved was crossing the MIC level for most of the organism except Pseudomonas. So again, when you are dealing with cases other than Pseudomonas, oral antibiotic do have a role. So this is also published in Eye and Contact Lens. So I think I'll conclude here with this. So remember, the drug that you are prescribing, even if it reaches the cornea, it may not be working because there may be antibiotic resistance or the patient factor may be playing an important role. Clinical diagnosis is not good enough to start antifungal drugs. Corneal biopsy in fungal keratitis is extremely useful. Oral antibiotic you should use whenever you feel the patient is not responding to topical drugs. With this, I'll conclude here. Thank you so much.
Thank you so much, sir, for that talk. And just one brief question, sir, that you've said that natamycin and voriconazole both are not working in a lot of cases. So what is your preferred next choice of drug?
So if natamycin and voriconazole both are not working, so you can explore experimental drugs like posaconazole we are trying, but even with that also the results are not that much encouraging. Or you can go for isonacandins, but again experimental studies are not that much encouraging. So what I feel, if somebody is not responding to natamycin voriconazole, don't wait, go for a therapeutic penetrating graft, debulk the cornea, that is the best approach. If the patient is not consenting for surgery, then you can try all these experimental drugs, intrastomal drug delivery. But natamycin, voriconazole, they are the tried and tested drug. If they are not working, unlikely that some other drug would work.
So one small question I would...
Amphotericin B?
Amphotericin B is specific to Candida. So we use amphotericin B in Candida, but in our practice, hardly there are 1 or 2 cases that we see. So we haven't done any study or included those cases in our group. But yes, in Candida, amphotericin B should be the choice.
So in your cases, in the biopsies that were done, histopathology, have you found out any cases of viral keratitis? Because mostly we're discussing bacterial and fungal.
Any cases of?
The cases who had viral keratitis which required penetrating keratoplasty. What were the histopathology features suggestive of that?
No, actually, Siddharth, the inclusion, these are all studies. So the inclusion criteria was, the exclusion criteria, viral keratitis, we excluded all patients.
Okay.
So That was the
mostly
probably.
So I was just thinking secondary infection usually leads to a therapeutic keratoplasty, but were there any features in histopath where you could
For
find?
histopath, you have to specifically ask the pathologist if we want to check for HSB, then only they would explore. So we didn't ask for them for that.
Yeah, okay.
So I can't say on that.
Okay, so we'll move on to the next presenter, Dr. Ashu Agarwal, who will be talking about capsule hooks and segments in the management of subluxated cataract.
Thank you, Pranita. Good morning, everyone. And thank you, Praful, for this opportunity. I'll be talking about the role of capsule hooks and segments in the management of subluxated cataracts. So this subluxated cataracts, I believe, is the last frontier still to be tamed by the experienced phacosurgeon. And for this, we need capsular support, which is in the form of internal or external support. And internal is by endocapsular rings, started with that, went on to Sionese rings and capsule segments. This is in the order of evolution. And external support initially was by iris hooks, but later on Dr. Makul's capsular support system came in, which are commonly known as capsule hooks and are specifically devised systems for capsular support. So let's quickly look at the difference between iris hooks and capsular support, why capsule hooks should be preferred. Iris hooks, if you see on the left side here, have a shorter return, and these are angulated relative to the capsule plane, thereby causing a tenting. And if the quality of manufacturing is not good and the ends are sharp, they may tear the rexus edge also. And the capsular fornix is not supported by the hooks as opposed to the capsular hooks, where you see they're long and parallel to the plane, and they support the capsule fornix also. So they have certain advantages that they support both the rexus edge and the capsule fornix and stabilize conditions during surgery. Let's look at the capsule segments. These are the segments. If you imagine a Sionese ring, essentially it's a truncated Sionese ring. And if you compare the two, Sionese rings, if you've used them, are very flimsy, and surgery can be very tricky with a Sionese ring and 10 or 9 proline sutures all coming together. And segments are smaller and therefore easier to handle. However, Sionese has the advantage of a circular expansion of the bag, but this can be offset by an additional CTR implantation with with segments if required. Briefly, the technique highlights, you can do on the topical or peribulbar, whatever you prefer. Corneal section should be furthest from the area of subluxation. We should layer viscoat in the area of zonular dialysis to prevent hydration of the vitreous. Capsulotomy is started usually with a cystotome completed with the utrata. Ensure an adequate rim of anterior capsule around the area of dialysis, otherwise the segment will pop out. Rexus is centration is maintained with respect to the lens diameter and not the pupil, and a properly placed rexus would actually appear eccentric, and the size should be about 5 millimeters. And they are usually placed after rexus, the hooks, and through relatively vertical incisions. They should not be too beveled, in intervals of 90 to 45 depending on what the case is. Do not over tighten, just a small little tug is required, and removal is very simple. By freeing the capsular edge, you just pull it out, and the incision should be hydrated. The hydro procedure should be gentle, and a slow motion phaco should be done, and capsule segment is usually implanted after nucleus removal. Irrigation aspiration should be very careful. You should not catch the fornix or the rexus edge, and IL implantation is done by no or minimal dialing. Let's quickly look at a video just to highlight the role of capsule segments. So there's a central eyelet through which the 10 or 9 proline is threaded. A railroading technique is used, a 26 gauge needle. I prefer to use a partial scleral tunnel, which just ends here. The advantage is that the knots get buried itself. Here the 10 proline is brought out. Again, the similar one, a railroading is done again. This was the first one I ever did, and with the indigenous ones, this was the first video ever recorded. The ones, because we now have them in India also. And the segment is gently introduced inside. This is the first one, so you'll see a bit of a struggle there. That part's not been edited. And it's brought into place, and then it has to be introduced inside the capsular bag. So if you notice, the arc length of the segment is more than the rexus diameter. So carefully bring in one end, followed by the other.
So I always keep a spatula beneath it and then.
And then it's gently brought into place, and the sutures are pulled.
very small.
to get the rexus edge to abut the, the segment to abut the rexus fornix.
ये कौन बना रहा है ये?
Then the sutures are tied. They should not be too tight, just a gentle tug should be there. This shows that it's adequate. The knot gets buried itself. The IOL is implanted and dialed into place. These are the post-day of 1 day post-op pictures. In the dilated state, you can see a little tug here, just a gentle pull. That's enough. A post-op pic. Then a second video showing a combined use.
इनका. Let me use it. क्योंकि हमारे पास तो बहुत आते हैं patients.
So you see this, there's about 3 clock hours over here, 2.5 to 3 clock hours actually. The rexus is performed, and then the capsule segments are introduced through 3 ports. So when you have a generalized laxity, 90 degrees spacing is enough. For the areas of dialysis, 45 should suffice. Here I've put an additional one in the center. Again, a slow motion phaco, as they say, is done. Irrigation aspiration is done very carefully. Right now I think, irrigation aspiration is done. Be careful not to catch the rexus edge or the fornix. So before introducing the lens, I want to create some space. I removed some additional hooks. This is the segment, the indigenous one. Again threaded and introduced. Brought into place and sutured for the scleral fixation. Similarly, the IOL is placed inside and dialed into position. And that's the end of the surgery. Post-op day 1 picture. Again similar, just a little gentle tug showing that this is adequate support. Thank you for a patient hearing.
Thank you so much, sir, for those beautiful videos. So, do you use, have you ever done double CONI or double CTS in cases with subluxation more than 6 clock
Double
hours?
CTS, yes, definitely opposite. Double CONI, you mean the 2 arm?
Yes.
You don't use the double CONI.
Double arms, yeah.
Yeah, the 2 eyelets.
Eyelets.
Yeah, we've done all that. But now after the segments, I just prefer, because CONIs, if you used it, there's
Bulky.
these proline sutures coming in. No, it's very flimsy. Then
Yeah.
there's a proline suture. Sometimes it can be a total mess. So I was always very unhappy with this CONI till the segments came in. And the interesting thing is, I observed these in the US, and I came back and I was at Venu and in fact I had left. I had talked to Dr. S.C. Gupta. So I was the one who motivated. He said, yeah, let's just chalk out a design. So we did a rough thing, and then that's how it. Just the first one was the first. There was rather the prototype.
Okay.
So I'd like to in fact thank Dr. Gupta, Madhu Instruments, for bringing so many good devices for us.
Yeah.
I think he's amazing, you know. I motivated him for getting a spectacle mounted telescope,
Oh, yeah.
and he came out with that, and we just put 2 in the children, and they're so happy with the low vision. One question on this, for the scleral tunnel, beautiful video, beautiful surgery as usual, Ashu. Have you tried Hoffman
Hoffman's
technique?
Yeah, I know. So somehow I knew that would come. So somehow I don't know. My personal preference is, you see, tunnel is so simple, so intuitive. Anyone, in fact, who's done a SICS or started with phaco when you might, Rakesh, remember we used to do when we were putting in. Actually, the thing is in Venu or charitable organizations or eye care also, for that matter. We used to put in these PMMA lenses, 5 mm lenses, 5.25 mm lenses through the tunnel if the section in poor patients or if the astigmatism was too high. So everyone's very comfortable with the, the crescent knife and tunneling and all. So you just do a 2 mm thing or a 1.5 mm and introduce your needles there, the 26 gauge, and railroading is very simple. And the knot gets buried. So for some reason, I just prefer this.
So the segment for the Hoffman tunnel in the side where just the serial tunnel is there,
I know.
not for the main port. Main side you can keep one.
No, I know. That's what you. That's
Yeah.
what I know. So that side, in fact, main is a corneal tunnel.
Yeah.
So the where the railroading is happening, the 26 gauge are going.
So what I would say is you can do railroading from one side from the main tunnel, and the other side you
You
have
just
a
put a
Hoffman,
Hoffman's, yeah.
because that will be much. The nasal side is left, and the other things. As a glaucoma person, we want more of the limbus to be left intact.
Yeah, so that doesn't doesn't get impacted over here, no? Your surgery will be safe.
I think the next session people are waiting for their turn. So with that, we'll conclude the session and we can call all the people on the dais and the speakers for the common group photograph.
I thought these two were trying to learn subluxary cataract management, but they don't need to. They'll just knock it and then remove it. Thank you.